Welcome back to Decode Healthcare with Harshal. So, in part 8 of our musculoskeletal series, we absolutely conquered the forearm in rest. Today, in part 9, we're jumping right into the incredibly delicate microsurgery of the hand and fingers, specifically covering CPT codes 2610 through 2699. Let's get right into this explainer because, trust me, coding for the hand is a totally different beast. It requires absolute precision. Here is our roadmap for today. We're looking at hand anatomy, the golden rule for coding digits, how to handle trigger fingers, complex tendon repairs, and finally, fractures and pins. All right, section 1, hand anatomy. Visualize to code. You really can't code what you can't visualize, right? So let's map out the territory. There are 3 main zones of hand bones you need to know. Starting right at the base near the wrist, those are your carpal bones. Moving up into the fleshy main part of your palm, you've got the metacarpals. And finally, extending all the way out are the phalanges. Those are the actual finger bones. When you're reading an operative report, your brain needs to immediately flag which of these 3 zones the surgeon is working in, because a procedure on a metacarpal in the palm is coded completely differently than a phalanx out at the fingertip. It's a whole different neighborhood. Moving on to section 2, the golden rule of hand coding. Before we even touch a surgical code, you've got to understand this overarching logic. The absolute most important rule here, and I literally cannot stress this enough, is that procedures are usually coded per specific digit or bone. You have to be a detective and meticulously track exactly which finger the surgeon is fixing. If they fix 3 fingers, you code for 3 fingers. How? By appending specific modifiers to your CPT codes. You'd use FA for the left thumb and F1 through F9 for the other specific fingers. Without these modifiers, the insurance payer is essentially flying blind. They have 0 clue if the surgeon worked on the index finger or the pinky. Which brings us to section 3, trigger finger, freeing the tendon. Let's look at the first major battle our hand surgeons face, the trap tendon, more commonly known as a trigger finger. If you look at the incision codes, specifically between 260-110 and 260-80, you'll spot code 2605. This one is precisely for a tendon sheath incision to release a locked trigger finger. So, what is a trigger finger? Well, it happens when the tendon that bends your finger gets inflamed and basically gets stuck inside its protective sheath. It actually causes the finger to physically lock up in a bent position. Sounds painful, right? So how do they fix it? In plain English, the surgeon finds that inflamed sheath, specifically an area known as the A1 pulley, right at the base of the finger. They take a tiny scalpel, make a small incision, and slice that tight A1 pulley wide open. Bam! This immediately frees up the tendon, giving it room to breathe and glide smoothly again, so it totally stops catching. Whenever you see this exact sequence in a report, 26055 is your go-to code. Next up is section 4, tendon repairs and reconstructing the hand. We're shifting gears now from just freeing trapped tendons to actually fixing severed ones. The repair and reconstruction section covers codes 26340 through 26596, and it gets incredibly detailed. It covers everything from pulley reconstruction to cross-intrinsic transfers. The big question you always need to ask yourself here is, are we dealing with flexor tendons, the ones that bend the fingers, or extensor tendons, the ones that straighten them out? Tendon coding relies heavily on exactly where the injury is, the specific zone of the hand. Think about it. Repairing a delicate flexor tendon deep down inside the palm is a vastly different surgical ballgame than fixing an extensor tendon right at the very tip of the finger. The CPT codes differentiate based on these specific zones, whether it's a primary or secondary repair, and if it needs a free graft. You really have to break out the magnifying glass and read the operative notes closely here. All right, that brings us to our final anatomical battleground, Section 5, Fractures and Coding for Broken Bones. This section covers codes 26600 to 26785. Now, you are going to see a really critical CPT term pop up here, percutaneous skeletal fixation. What does that actually mean? The CPT guidelines define it simply and elegantly. It just means the doctor takes a thin metal pin, often called a K-wire, and drives it straight through the patient's skin directly into the fractured bone to hold it perfectly straight. The huge takeaway? They do this using X-ray guidance, without making a big open slice into the hand. It's a minimally invasive, super effective way to pin a fracture together. Speaking of slices, it's absolutely crucial to know the difference between treatment types when coding these. A closed treatment means the fracture site is not surgically opened up to the external environment. The doctor might just manipulate the bone from the outside. But an open treatment?
That means the surgeon literally cuts the site wide open to directly look at and fix the bone, often dropping in plates or screws.
Let's apply this to a real-world scenario. Say a patient comes in after punching a wall in frustration. Classic move, right? They end up with what's called a boxer's fracture, a break in a metacarpal bone right in the palm of their hand. You jump over to the metacarpal fracture codes. If the surgeon stabilizes that boxer's fracture by driving those K-wires through the skin, you'd look at code 26608 for percutaneous skeletal fixation of a metacarpal fracture. And hey, remember our golden rule? The code description explicitly states each bone. So if two metacarpals are broken and pinned, you literally code it twice. Simple as that. So we've just mastered the intricate, microscopic precision required to code for the delicate bones of the hand. Awesome job today. But I want to leave you with this. If the hand requires this much detail for tiny K-wires and tendons, how intense do you think the coding gets when we start dealing with massive, weight-bearing plates and screws? You definitely don't want to miss our next explainer. Make sure you're subscribed, because in part 10 of our series, we're journeying down to the lower body to decode the pelvis and hip joint. I will see you all there.